going to switch gears and talk about an arrhythmia, atrial fibrillation, which is, as you know, extremely common, getting more so. Probably some of you in the room, or many of you in the room, have had atrial fibrillation. Won't take a poll, but we could talk about it a little bit later or in the smaller groups. So just as a reminder, what is atrial fibrillation? Normal electrical activity of the heart, as you recall, starts at the sinus node, goes to the AV node, and then down to both bundle branches. Atrial fibrillation, on the other hand, is chaotic electrical activity. Happens in both the atria, and then the electricity goes to the AV node, and whatever can get through the AV node does, runs down to the ventricles, and then causes the very irregular rhythm that we know as atrial fibrillation. It's an epidemic, really. There are increasing hospitalizations for atrial fibrillation. This data looks at prevalence per 10,000 persons with a principal diagnosis of atrial fibrillation when hospitalized. And what the different lines show is that as the red is 85 plus years, 75 to 84 is this sort of tan color. And so as our patient population gets older, atrial fibrillation prevalence goes up. There's no reason to think that that will change anytime in the near future. This is a projection out to 2050 in terms of how many people or how many adults will have atrial fibrillation in the millions. We start here in the late 90s, early 2000, in the 2-something million, and out here in 2050 we anticipate 5.6. So again, this disease is not going to go away anytime soon. Atrial fibrillation, as you recall, adversely affects quality of life. These colors are kind of funny, but AFib is this darker brown. Post-myocardial infarction is the middle bar, and then control here. And interestingly, quality of life with AFib is very similar to that you see with post-myocardial infarction, which is in all areas of quality of life: general health, physical function, social function, and mental health. The natural history of atrial fibrillation is characterized by a gradual worsening over time. Your patients will ask you that. They say, well, there are several things they ask you. The first thing is, how come this is happening? General answer, which most people don't want to hear, is because you're getting older. This is just the answer. I mean, by the time our population is 80 years of age, 20% of your patients will have atrial fibrillation. And they say, well, will it get better? The answer is no, that it gradually gets worse over time in general. Treatment may halt progression and improve symptoms, but our patients need to understand that we can't, aside from atrial fibrillation ablation, which I will go over in just a moment, aside from some curative ablative procedures, this is a disease that we manage, that we treat, but that we cannot cure. I mean, with all the different treatments, for example, the valve treatments we just heard about where we can fix things, in general, this is not something that we can fix, but something that we can help our patients manage. There are different classifications. It just helps you think about how you want to treat people. It's not important to necessarily definitively label patients as one of these, but we categorize people as paroxysmal, which means that the atrial fibrillation is still in the stage where it's coming and going and terminates by itself. Persistent atrial fibrillation is greater than 7 days and requires cardioversion. So these are the patients who are in AFib. They don't pop out of it by themselves, but they can be cardioverted and maintained back in sinus rhythm if that's the route that you choose. Long-standing persistent is atrial fibrillation that has lasted more than a year. In general, as the atrial fibrillation becomes more and more long-standing, the chance that you'll get them back into sinus rhythm, if you elect to do that, is smaller, and then permanent means you've just given up and they're going to stay in AFib, and that's that. So managing atrial fibrillation, this is the part that is becoming increasingly complex. I'm sure many of you in the room, I know I remember when I was an intern, the only treatment for atrial fibrillation was digoxin or digitalis, and you just hammered your patients with it until they almost had a junctional rhythm. There was no, we didn't have to think about, beta blockers, antiarrhythmic drugs, ablations, His ablations, whatever. It was just dig, that was it, that was their treatment. And as you know, it's gotten way more complicated than that. So for the acute treatment of atrial fibrillation, patient shows up in the emergency room or in your office with atrial fibrillation that's going pretty fast. We want to control their ventricular rate. You can do that either with calcium channel blockers, beta blockers of your choice. Digitalis is a little bit less effective, but we still keep it in our toolbox. And then you can elect to restore sinus rhythm, either with intravenous therapy, with ibutylide is the most common one used now, or DC cardioversion. When you're thinking about atrial fibrillation, it seems like, at least I feel like, people think that we just sort of make it up as we go along as electrophysiologists about what we're going to do with each different patient, but we actually have a thought process on it, and I'll try to sort of walk you through that. Because there aren't that many medication options for treating AFib, and I'll give you how we think about that. When you're trying to decide how to take care of this problem, it's either rhythm control, which means you're going to maintain the patient in sinus rhythm, rate control, which means you've given up with sinus rhythm, but you do want to still maintain a reasonable ventricular rate, and anticoagulation. You have to decide whether the patient needs to be anticoagulated for the rest of their life. This is the AFFIRM trial, which you've all heard about. It's from it was published in many years ago, the latest iteration, 2002. But the AFFIRM trial looked at patients in atrial fibrillation and whether you should maintain sinus rhythm or if rate control was also okay as a treatment strategy. Prior to that, remember, we felt very strongly that everybody deserves to be in sinus rhythm. And so this trial changed the way we thought because it looked at rhythm control versus rate control, and there was no difference in cumulative mortality. So leaving patients in sinus rhythm or leaving them in atrial fibrillation didn't make a difference. So this trial changed the way that at least the EP and cardiovascular community thought, and now no longer were we obligated to have everybody in sinus rhythm. Rate control was also an okay option. So say you decide to put your patients into sinus rhythm, what are your choices? And this is where people get confused and think that we just pick out of the air today what I feel like using in this particular patient. There's actually a thought process behind it. These are the only drugs we have. So class 1 antiarrhythmic drugs, the sodium channel blockers, procainamide, quinidine, disopyramide, we don't use these anymore. And if you're writing new prescriptions for quinidine, then you're dating yourself to 20 years ago. We occasionally have patients who really just love their quinidine. Those patients are becoming fewer and fewer. So you can write old prescriptions for quinidine, but I wouldn't be prescribing that anew. Disopyramide, every once in a while we still use it for vagal atrial fibrillation, but that's also very few and far between. Lidocaine and Mexatil, remember, have absolutely no atrial activity, and so neither of those drugs is a choice. And then the 1C antiarrhythmic drugs, flecainide and propofenone, are used in patients with completely normal hearts, no coronary disease. Class 2 are the beta blockers. Most of our patients take beta blockers. Class 3 antiarrhythmic drugs, potassium channel blockers, are sotalol, amiodarone, dofetilide. Ibutylide is only intravenous. And now we have the dronedarone as another choice. So when you're thinking about antiarrhythmic drugs, your choice are really flecainide or propofenone, patients with a normal heart, or sotalol, amiodarone, dofetilide, dronedarone. Usually these two for patients with an abnormal heart or people with previous MI or coronary disease. And then calcium channel blockers, and that's really it. Those are our only choices. In a patient with lone atrial fibrillation, a normal heart, no coronary disease, which choice is the best antiarrhythmic drug? Procainamide? No. First of all, I don't think they have an oral formulation anymore. Second of all, that's in that line of drugs that I said don't use it unless you want to date yourself 20 years ago. Procaine, quinidine, disopyramide. Flecainide is a class 1C antiarrhythmic drug. Is that good for patients with normal hearts and no coronary disease? It's a great drug for a patient with normal heart and no coronary disease. Most people cannot tell they're taking it. Amiodarone, I see people give that a lot for normal heart and no coronary disease patients. It's got a lot of side effects that are toxic, so that is not my first choice for somebody who otherwise has a normal heart. So I would say flecainide. Dronedarone is sort of the new kid on the block. It was released over a year ago now. Time flies. In 2009, the FDA approved it. So this was released in 2009 for atrial fibrillation and flutter only. It has some adverse reactions in patients, especially importantly, death in patients who have had a recent exacerbation of heart failure, and so it cannot be used in patients with heart failure. Now, they make a differentiation in the black box, and they say in patients with recent severe heart failure, but at least in the EP community, we've sort of generalized that to people with heart failure. We just back away from it and don't use it in that population. Most common adverse reactions, and they are pretty reasonably common, at least in my initial experience with this drug. There are a lot of GI side effects that prevent people from taking this drug. There's diarrhea, nausea, vomiting, fatigue, and just sort of a general sense of malaise. So some people can take this drug. It has its place, but I don't think it's become as common as the manufacturer originally pictured. And then no use in heart failure. So this is the complicated-looking maintenance of sinus rhythm algorithm, but we just went through it, and you heard actually how straightforward it is. So think about it. So no coronary disease, we said class 1C drugs, flecainide or propofenone. The rest of them were secondary. Hypertension with no LVH, that's a normal heart, flecainide or propofenone. So normal heart, the class 1Cs. If they have significant LVH, then you probably go down to the class 3 antiarrhythmic drugs, coronary disease, class 3 antiarrhythmic drugs, as we said, and heart failure, class 3 antiarrhythmic drugs, no dronedarone. So those are really your choices. The main decision point is heart disease, no heart disease. So dronedarone can be considered in the patient with AFib with recent heart failure. No. AFib who has failed flecainide? Sure. Because you've tried them with a 1C and you want to move on to something different, dronedarone is a reasonable choice. Atrial fibrillation with a rate control strategy only. Well, no, because we're not trying to get them into sinus rhythm anymore. The antiarrhythmic drugs have no place in rate control. And symptomatic PVCs requiring suppression. Remember, dronedarone's only indication is atrial, so atrial fibrillation or flutter. So you do not want to be using it for ventricular arrhythmias unless you know that you're using it for a very off-label use, but there are a lot of other drugs you can use for that. So on to atrial fibrillation ablation. The most striking breakthrough recently was the recognition that in some of these patients we actually can cure atrial fibrillation. I had the honor of being at the original, I think I was one of the co-chairs at the abstract session where Michel Hasseguer presented his information about Ablation, and I'm embarrassed to say I was one of the people I thought, that's not going to work. But it has since then really sort of caught on fire, and bottom line is that atrial fibrillation was found to be triggered by some rapidly firing foci from the pulmonary veins, and then they could be cured with catheter ablation. And this is just a schematic showing that there is some atrial tissue. If this is the atrium down here, there's some atrial tissue that goes up into the pulmonary veins, and then these foci fire, and they fire so rapidly that they induce atrial fibrillation in the atrium. And then the very simple thought process about how to take care of this is to make an ablation line around the pulmonary vein, as demonstrated here, this being an ablation catheter, so that when this electrical activity happens and fires, it cannot get across that line of ablation. The electricity can no longer cross there, and so it can't affect the atria. This is a schematic of how we do that. Catheters up through the right atrium, across the transeptally into the left atrium, and then these are the pulmonary veins. We make a circle around the pulmonary veins so that anything coming from the pulmonary veins can no longer electrically contact the atrium. So the justification for AFib ablation is symptomatic atrial fibrillation with the goal of improving the patient's quality of life. Atrial fibrillation doesn't change the patient's stroke risk, and and improved survival have not been evaluated in a large randomized trial. The indications for a catheter ablation, there are people in this country who will tell you that AFib ablation is first-line treatment for AFib. You have AFib, off you go to the ablation lab. I don't believe that, and neither do our boards, Heart Rhythm Society, the ACC, these are the European Society, tell us the indications for catheter ablation are symptomatic AFib that is refractory or intolerant to at least one class 1 or class 3 antiarrhythmic medicine. So we like to see people fail some antiarrhythmic treatment before we send them for atrial fibrillation ablation. It is second-line therapy. One of the reasons is the outcomes are not 100%. One procedure cure for paroxysmal atrial fibrillation is somewhere between 40 and 80%. That goes up a little bit with more than one procedure. Persistent AFib is less, 20 to 40%-ish. More than one procedure, and we're not just talking two, more than one can mean multiple procedures. It's still not 100%. Outcomes vary depending on the patient and as well the operator, as well as their size. Complications are not inconsequential. 6% is a fairly high complication rate for a procedure. Most of the stuff we do is less than 1%, especially in the ablation laboratory. So we can see tamponade, we can see pulmonary vein stenosis. Atrioesophageal fistula is 100% fatal, 100%. Phrenic nerve injury, these are smaller things, but still a complication rate of 6%. So all patients should be referred for AFib ablation before other strategies are considered? Absolutely not. Rate control, rate control isn't very interesting. It's beta blockers, calcium channel blockers, digoxin. There are a couple interesting things that came out recently. We've always worried about very strict rate control to make sure, and so we hammer people with beta blockers until they can't move. This trial looked at lenient rate control with the hypothesis, that it was not inferior to strict rate control, and looked at a composite of mortality, heart failure, hospitalization, so on. Lenient is 110 beats per minute or less, strict is less than 80, and the outcome was similar in both arms, which gives us a little bit of leeway with our patients and lets us not make them so tired on their rate control drugs. We can let them go a little bit faster. Interestingly, stroke was decreased with lenient rate control, and then all the endpoints were similar. The other interesting aside is this trial looked at we worry in our heart failure patients that we have to keep them in sinus rhythm because they need that atrial kick or they're not going to do as well as they would otherwise. This study looked to see whether the prevention of AFib would improve survival in patients with heart failure. Pretty big trial, 123 centers, 1,300 patients. And interestingly and surprisingly to some of us, there was no difference in mortality, cardiovascular mortality, stroke, or worsening heart failure. More hospitalizations, but that's probably because people were cardioverted. So in heart failure, the authors say that rate control may be considered as a primary approach in these patients. You don't necessarily have to keep them in sinus rhythm. Anticoagulation, just one word on that, choice of therapeutic strategy, so rate control, rhythm control, ablation, whatever, does not affect your decision regarding anticoagulation. So we used to think that if patients were in sinus rhythm, we could take them off their Coumadin. That is no longer what we think. So therapeutic strategy doesn't change whether or not they need anticoagulation. So you may stop anticoagulation in the following situation. Successful AFib ablation, no. Successful cardioversion, no. Successful rate control, no. So the answer is none of the above. You don't stop the anticoagulation if they have an indication for it. So to wrap up, AFib is not a single disease, and it cannot be managed with a single approach. Therapeutic strategies should be individualized, and I thank you for your attention.